Good evening. My name is Karen, and I'm a Community Education Coordinator for Boulder Community Health. I'd like to welcome you to tonight's lecture on latest treatments for heart valve problems. I'd like to go over the format for the lecture. The lecture portion will last about 45 minutes. Afterwards, we'll use the remaining time for questions. Please type your short general question in the chat box below the video on your screen. We'll get to as many as we can. On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Dr. Srini Iyengar. Dr. Iyengar is a board-certified cardiologist who is fellowship trained in cardiovascular medicine and interventional cardiology. He attended medical school at Ross University with subsequent internal medicine training, including a year as chief resident at the Jewish Hospital, University of Cincinnati. He then completed a heart failure and transplantation fellowship and a general cardiology fellowship at The Ohio State University. This was followed by a 2-year advanced interventional cardiology and structural vascular fellowship at Columbia University. Dr. Iyengar leads the structural heart care program at Boulder Community Health and sees patients at Boulder Heart in Boulder and at Erie Medical Center. Welcome, Dr. Iyengar.
Thank you. Well, thanks for tuning in tonight. And tonight we are going to be talking about the latest treatments for heart valve problems. But before I begin, it's really important because heart valves, the problems that they have, there's a lot of different things we can talk about. And unfortunately, we only have about an hour's time. So to break down these problems into some basic issues is what I want to do right off the bat. We're going to be talking about basically two particular valves, the aortic and the mitral valve, and two particular conditions associated with these valves. With the mitral valve, it will be regurgitation, which means leaking. With the aortic valve, I'll be talking about stenosis, which means calcium or tightening or basically inability to open. So the background. Historically, a number of cardiac conditions could only be treated with open heart surgery. Given the increasing age of our population, in addition to the multiple comorbid issues involved, the risk of complications of operating on this population has also gone up. So medical technology had to fill the void and see how we can help people who cannot get open heart surgery safely, and basically offer patients another pathway and potentially maybe even a better pathway. So let's go in the background again. 30 years ago, the use of coronary balloons, PTCA otherwise known as, followed by stents, revolutionized acute coronary syndromes. Basically, if you came into the emergency room over 30, 40 years ago for a heart attack, all we had were blood thinners. We would just give you a blood thinning medication. Then we had balloons to go into your arteries to open the blockages. And then we had stents. So it shows you how things have evolved in the last 30 to 40 years. We have now pacemakers implanted without open heart surgery, which changed the dynamic of heart rhythm disorders. But the one major area that was not successfully addressed were basically structural heart procedures like the valves or the appendage of the heart, things that were purely surgical. So then in the last 10 years, we saw some major changes. So I'm proud to be part of the structural heart revolution. Since I finished my training, and post-training, things have evolved. So it's a revolution, not just an evolution. We now have the capability to address serious internal cardiac issues with minimally invasive techniques. Results with certain procedures that we do have now shown to be equivalent, if not better, with certain conditions than surgical standard of care. And this movement only seems to be gaining strength with newer technologies entering the cardiac arena every year. The first condition I'm going to talk about tonight is mitral regurgitation. Again, the mitral valve is one of the four valves of the heart. It's the valve that's between the left atrium and the left ventricle, and this condition, regurgitation, means leakiness. So in your minds, when you hear regurgitant, that means the valve is leaking. This condition affects thousands of Americans, vastly undertreated, and basically means the mitral valve has become leaky, like I mentioned, which blood spills backwards into the lungs rather than going forward into the left ventricle as a result of a weak or degenerated mitral leaflet. The results are progressive shortness of breath, fatigue, and eventually heart failure. So what are the causes? Well, we have one condition called degenerative mitral regurgitation, or MR, which basically means that there is an abnormality in the valve itself. The valve has a leaflet that's torn, or one of those cords that are on the bottom of the leaflet are torn, and things change in the actual anatomy of the valve. Functional MR, also known as secondary MR, is the result of the left ventricle dilating, and it actually stretches the valve out. And once that valve gets stretched, there's more leaking because it can't actually close properly. Moderate or severe valvular disease, mitral regurgitation, is common and increases with age. It's the most common type of heart valve insufficiency in the USA, and the prevalence increases with increasing age, from 0.5% for 18 to 44-year-olds, rising to nearly or greater than 9% in greater than 75-year-olds. So it is a condition that changes with age. This is the vicious cycle of mitral regurgitation. Once mitral regurgitation starts getting worse, it basically makes the increased load and stress of the heart to work harder. So you see muscle damage and loss because the heart's working harder. Eventually that leads to dysfunction of the left ventricle. Once the left ventricle dilates, it basically then starts going into more mitral regurgitation, and you see the cycle continues until an individual develops end-stage heart failure. It's not a good thing to have. So 50% of patients with severe untreated mitral regurgitation have a mortality of nearly 57%. So what's the treatment? Historically, only medical therapy followed by surgery, if possible, were mainstays of treatment. So what are medical therapies? Well, obviously, we really want to make sure that we treat the symptoms, which are usually shortness of breath. So what do we give for people with fluid in their lungs? Something called diuretics, water pills, very commonly used, and they do work very well. The problem is you're treating the symptom, not the problem. So we may be able to get the water out of the body, but we're not necessarily treating the underlying valve issue. If someone has high blood pressure, treating that can treat the leaking mitral valve very well. However, if someone doesn't have high blood pressure and a leaky valve, there's only so much blood pressure medication can do. Surgery has always been the gold standard for severe mitral regurgitation. The thing with surgery, though, is it can be somewhat complex and stressful to the body. Hence why we really have to be careful about which patients undergo which procedures. So at this point, we basically have to utilize that every patient that comes to see us with this condition, we look at from a perspective of what is their condition, what does their valve look like, how do they look like overall. We're lucky here at BCH that we have excellent valvular heart surgeons. Dr. Brian Mahan and Dr. Miles Guber are fantastic mitral valve surgeons who do not only mitral valve repair, but mitral valve replacements, minimally invasive mitral valve repair, as well as traditional open chest repair. So we have the surgical expertise to do these procedures. But unfortunately, there are patients who are still too sick or too frail to even have the minimally invasive mitral valve surgery. And that's where I will go into my next slide, which is the MitraClip system. This was developed for patients who are just too sick, the inoperable or extreme high risk patients who could not get even the minimally invasive mitral valve surgery. The MitraClip system is a percutaneous, which means it goes through the skin like a needle into the vein versus an open chest procedure, and goes into the heart to put this device in. With a beating heart, there's no bypass. There is no indication for open chest procedure. There's no indication for other tubes and lines to be placed in other than the anesthesia. So this is a procedure that actually has changed the ball game for patients who have very sick, inoperable mitral regurgitation. There's been really, really strong data to support successful outcomes for patients performing this procedure or undergoing this procedure. At this point, I'm going to show you a video. It's probably best to explain as we see the animation of what this MitraClip actually looks like and what it does in the body. So here in this video, this is actually the beating heart that we're seeing right now. And as we get closer, you can see how it's been listed, the atriums and the ventricles. And on the left side, what is right there is blood coming into the atrium on the top and it's going to the ventricle on the bottom. As this video is running, this is a normally functioning heart. Now we're going to start seeing what happens when blood actually doesn't flow normally. And as you see there, that's the label of the mitral valve. This is the normally functioning heart. Blood coming in from the lungs to the left atrium, getting pumped into the left ventricle through the mitral valve, and then from the left ventricle out the aortic valve to the rest of the body. This is what happens though when the mitral valve isn't working properly. It almost looks like a volcano funnel coming back into the left atrium. Every time the heart beats blood, takes blood to the ventricle, it pumps it right back up top into the left atrium. And what we're looking at is issues with the mitral valve itself. Is it the leaflet? Is it the leaflet being stretched? What is actually ongoing here to cause this to happen? And we see here a microscopic or histologic examination of the leaflets and the cords to show you how stretched and dysfunctional they're becoming with mitral regurgitation. As time goes on, this will result in that heart muscle actually becoming weaker and more dilated. So we want to catch the patients before this happens, and that's where this MitraClip procedure comes in. For the patients that are not adequate or appropriate surgical candidates, this is the device that has been developed. This part of the device is actually outside the body. And what we do is make a tiny little incision into the vein, and through the vein, we will actually thread up a wire to the right side of the heart. And then what we do is we make a puncture from the right to the left side. You do not feel this, you're under anesthesia, and this hole closes up by itself over a couple of weeks. Once this happens, we then insert the catheter into the left side of the heart. And as you can see, we remove that dilator and now insert that mitral clip. Once we place the mitral clip in, it can actually bend in multiple different directions. So we can actually position this wherever we would like across that mitral valve. It then opens up, as you see there, and our goal is to position this under echocardiographic guidance under the most likely source of the biggest leak. We place this under the valve and pull back, literally catching the leaflets in the clip's arms. And then, like a sandwich, we close it. If we like where the position is at this time, we recheck it before we do any releasing of the clip. We look to see if there's still leaking present. If there is, we decide to say, okay, maybe we need to move it slightly left, right, front, or back. We will go ahead and do that right then and there. Once it's done and we're happy with the release, we remove the clip sheath. And the result is obviously what we hope for is a reduction of that mitral regurgitation. So with that being said, I'd like to move on to our next topic, which is aortic stenosis. So I just talked about the mitral valve leaking. Now I'm going to talk about another valve called the aortic valve, and not leaking, but rather aortic stenosis, which means it's not opening. Aortic stenosis, or AS, can be seen earlier in life as a congenital issue called a bicuspid aortic valve, which basically means 2 leaflets, not 3. But it's more seen as an age-related calcific issue. Basically, aortic stenosis is a very real problem in the United States. It results in closure of the aortic valve from calcium and progression. And what it actually results eventually is people complaining of fatigue, shortness of breath, chest pain, lightheaded spells, and again, heart failure and possible death if untreated. The prevalence of AS, or aortic stenosis, it's estimated to be in 7% of the population over the age of 65, more likely to affect men than women, and 80% of the adults with symptomatic aortic stenosis are male. Demographics, we are seeing now an increase of aortic stenosis because a lot of the human population, the US population, is living longer. So we are seeing that when you start seeing some scarring on the leaflets of the valve called sclerosis, it does progress to eventual aortic stenosis in a significant amount of patients. But what causes it? Well, to be very honest, it's age-related calcific stenosis. It isn't caused necessarily by any dietary issues. I have plenty of patients that say to me, I'm going to stop drinking milk because I don't want to have aortic stenosis. And that isn't the answer, especially with women, because of low calcium, as postmenopausal women often need more calcium. Please keep drinking your milk, taking your calcium supplements. A number of issues related to aortic stenosis is age-derived. So the older you get, it is just going to be more preponderant. Rheumatic fever, which was a condition we saw a lot 50, 60 years ago, which we don't see as much anymore, was a cause of it. And then, of course, like I mentioned, congenital issues like bicuspid aortic valves. But generally, patients who develop bicuspid aortic stenosis develop it younger, 5th, 6th decade of life, where people who have age-related calcific stenosis are 7th, 8th decade of life. Now, there's an old saying, diseases don't read textbooks. So this is not something we always go by every patient. However, this is generally what we have seen. Risk factors. So increasing age, just like I mentioned, you get older, the chances are more likely that this develops. The male gender, as I mentioned before, high blood pressure, smoking, elevated LPA, which is a very hot button issue right now because everyone's talking about LPA. The problem is we really don't have a treatment for LPA at this point, so it's really just a marker, but we don't have anything to actually target it. And obviously elevated LDL cholesterol. If you have smoking, hypertension, elevated LDL, guess what? You're at risk of high risk for vascular events of any sort. So it makes sense that you're going to develop any type of disease process with any of those risk factors. This slide is really, I would say, probably one of the most important slides that I will show all night. Aortic stenosis is life-threatening. It progresses rapidly when symptoms develop. So the slide is a little bit of a misnomer. It's not that you will develop quick symptoms just because you have aortic stenosis. Rather, if you look at the slide, you go through a number of decades of your life, from zero to see that slide, maybe in the mid-60s, with really nothing. I had patients who are literally not feeling an issue at all because they're still in that sweet spot where the curve is very flat. But once symptoms start, that's when the curve drops, and drops quite dramatically. So we don't want to wait for patients to be in heart failure or in the emergency room or needing to be on diuretics to then say your valve is bad enough to fix. Rather, we like to keep a very close eye. And personally, every 6 months sometimes I will repeat an ultrasound of a patient who has severe stenosis but no symptoms, just to make sure that nothing is changing. Because once I notice someone telling me, hey, I've noticed when I climb up the foothills, I'm really getting fatigued, but I can still climb, but I'm getting more fatigued. That's a red flag for me. That tells me maybe that valve is now showing itself and the symptoms are real. We don't wait for that person to say, I can't get out of bed anymore because I'm so short of breath. That's too late. We want to get people way early in the process because we know if we intervene on this disease process earlier, the muscle does better, the patients do better, and again, quality of life and quantity of life is better. But here's a sobering perspective. There are a lot of other diseases that actually have better prognosis in 5 years than severe inoperable aortic stenosis. A number of them are cancers. So it's strange when you look at some of these really scary cancers, lung cancer, breast cancer, colorectal, some of them have better prognosis in 5 years than severe inoperable aortic stenosis. And why is that? Because a lot of times people who have aortic stenosis don't present until later in life. And they mask or don't really reveal their symptoms until they're much worse. Unfortunately, when someone comes to the office in their 90s, who have other medical conditions, but they have this condition as well, they're not the best surgical candidates. So we were seeing this for decades, that patients were like, we have this condition, how are we going to treat it? Well, it's surgery only. We have no other treatment. Medicines don't work in aortic stenosis. So what do? Well, we have the thought process that surgery does help. However, you must get people earlier in the process, and they must be patients that can tolerate open heart surgery. So this was the great limiting factor when we deal with patients that have this condition. We know the valve replacement works, but we got to catch them early, and they have to obviously survive the surgery and do well afterwards. But there's a low percentage of aortic valve surgery in high-risk patients, because that's what it is. It can become high risk. You're replacing a valve in the heart, arresting the heart. There's no easy way to do this other than that process. So this situation made medicine, the technology that drives medicine, to change and say, what can we do to make this situation better, that we don't have to rely on open heart techniques to treat this condition. Briefly, open heart surgery becomes riskier with the older population. There's a longer need for hospital stays, rehab, treatment of comorbid issues. And the last 10 years, we've seen the revolution in aortic stenosis therapy. TAVR, transcatheter aortic valve replacement, which is also called TAVI, transcatheter aortic valve implantation in Europe. So they're interchangeable. TAVI and TAVR are interchangeable terms, basically came about. So what is it? It's literally placing an aortic valve in your heart with your heart beating without opening the chest. It's less invasive than traditional thoracotomy for patients considered too high risk for traditional surgery. To be honest, this slide's a little bit on the older side on my patients now. How can actually get this procedure? They don't have to be the highest risk patients anymore, or even intermediate or low risk. They just have to have the evaluation by a cardiologist and a CT surgeon who performs this procedure. When I first started training in TAVR, there was only one valve available on the market, and that was the Edwards Sapien valve. Since then, there's been 3 valves that are now commercially available. There was a 4th valve that was pulled off the market, and actually just tells you not every valve is the same. So that's why it's so critical to have evidence and data to support the utilization of what we do here. Because clearly, when you're putting a valve in a patient, you want the best possible results for the longest term possible. The valve that currently has the best long-term durability data and the most widespread use in different patient anatomies would be the Medtronic Evolut FX Plus. Excellent results from this particular valve from multiple studies from all the approved valves we discussed. But however, the Evolut valve has shown better results in high-risk patients receiving a transfemoral, that means going through the groin, the artery in the groin, as opposed to open heart surgery. Remember, the TAVR valves have only been around for commercial availability for just over 12 years. So we don't have the 20-year data that oftentimes patients will say to me, what's the 20-year, 30-year data on these valves? We don't know. So this is still an emerging, evolving process. But the good news is what we are utilizing currently, especially here at BCH, has the best long-term durability data. And this is a video of that Medtronic Evolut FX Plus valve. So once again, we see the beating heart, but this time, instead of looking at the mitral valve, we're going to focus on that aortic valve, which is the valve from the left ventricle into the big pipe, which is called the aorta. If you can see there, that valve is changing color and shape. That is basically the calcium that's being deposited on that valve. Once that valve becomes this way, what happens is, again, shortness of breath, fatigue, chest pain, lightheadedness. So if you are deemed to be a suitable candidate for TAVR, what we would do is bring you to the hospital. We would obviously prep you out, but not open any chest. That's not the plan here for doing this procedure, but rather your groin arteries, or sometimes an artery in the neck called the carotid artery. 90-some-odd% of the cases are done via the groin and the artery in the groin versus anywhere else in the body. So in this video, we place a catheter in the artery, not the vein, like the MitraClip procedure was. And we would go through this wire that's already in your heart that we placed, and we would place this valve across your aortic valve and release it. And the beauty of this valve is if we don't like where it's placed, we'll move it. And here, under its own pressure, it will be released, and the heart itself anchors the valve in place. No sutures, no types of anchoring equipment needed. This valve is in place, and it will sit there, and it will not move. And if we like the position, we then pull the sheath back, and the procedure is over. And the procedure can take as little as an hour and a half to perform, and patients usually stay in the hospital 1 to 2 nights. So in summary, heart valve disease is growing in the US population. These are not conditions that are going to go away. Rather, we're just identifying more of them. I also feel very strongly, though, that these procedures can only be done in conjunction with a very strong open heart surgical team. The reason is you need to have all the tools before walking into a procedure or even speaking to a patient in a room. Open heart surgery is an excellent tool for certain conditions. There are conditions where I feel like, okay, this procedure, the TAVR procedure, makes more sense than open heart, but there are plenty of times where open heart surgery would make more sense. What example? Well, what if the valve is leaky, not tight? That would be better for open heart surgery, not TAVR. What if a patient needs bypass surgery? They should have open heart surgery. What if the patient has a dilated or big aorta? They should get open heart surgery. What if the patient has multiple problems, like a leaky mitral valve, a tight aortic valve, and maybe AFib and a blocked artery? That's open heart surgery. So there are plenty of conditions where open heart surgery still is vital, that we utilize our surgical colleagues in our procedures. So it's not just a one-stop shop. It's not a one-shoe-fits-all. We really have to be careful and very mindful that these procedures add to what we do, but they don't take away from anything else. So at this point in time, both TAVR and MitraClip represent the forefront of the therapies that I described tonight, but they are certainly not the last. Thank you very much.
Thank you very much for this presentation tonight, Dr. Iyengar. We want to remind our audience tonight that now is the time to submit your general questions in the chat box below the video on your screen, and we will get to just as many as we can. And these are in no particular order. How long is it from the time it's decided that a valve repair is needed and when the procedure can be done?
So that all depends on how a person is. If someone is in the emergency room or in the hospital, like in an ICU bed, that's an immediate issue. That's something we would do then and there, that day or that night or the next day. If someone's seeing me in the office who is not overtly symptomatic or someone we can medically treat with, like I said, the water pills, then that would be something we would obviously take our time looking at all the test results, making sure we have the right answer before we do the procedure. But each person, it's a case-by-case basis. There's never a time where I can tell you it has to be done exactly the time frame for each particular person. Each person is going to be a little bit different.
Okay. What symptoms are most important to watch for in cases of aortic stenosis?
So the classic symptoms are usually the chest pain, the lightheadedness, the shortness of breath. But I tell patients the most common symptom I see is fatigue, and not fatigue that comes and goes. So if you had a bad night of sleep, you're going to be fatigued. That may not be your valve. I tell every patient that has severe aortic stenosis but doesn't have symptoms or doesn't admit to symptoms, walk up a hill. Walk up a flight of stairs, walk down the aisles of the Home Depot or the major supermarket, somewhere where you're doing a lot of movement, see how you feel. And if you feel fine, great. Do it again the next week or do it again that week. Let's see you keep doing it and see what happens. Now, if you notice that, hey, 3 months ago, I walked up 3 flights of stairs, no problem. But now I did 2 flights of stairs and I have to stop before I do the third. And that's every time you do it then, that's a sign something's changing. Now, if you tell me, hey, my hip hurts, my knee hurts, that's why I'm not walking the stairs, that's not your valve. That's orthopedic. That's a different talk by someone else. But I would say if you're breathing fatigue-wise, now a lot of people confuse shortness of breath. They're like, what does that mean? I'm not short of breath. I don't huff and puff. I'm talking about just not being able to catch enough oxygen when you're walking up a hill or too long distance. That is usually a sign that your heart's struggling to pump out oxygen to the rest of the body and to your lungs, and then that's why you're feeling that way. So subtle symptoms, but they have to be reproducible. If it's once in a while, it's usually not your valve.
Okay. How is it different if you're trying to get back in shape after not being in shape? How would you know the difference?
So that's difficult because each person has a different level of fitness. So it's impossible for me to tell someone, your fitness level has to be here because you're at this age and this is your background. That's impossible. Each person is completely individualized. That's why I never tell someone, oh, you've never walked up the foothills here or the Flatirons? Well, start doing it. That's ridiculous. No, I say, what is your day-to-day activity? And if they say, I do my laundry machine's in the basement, I go up to the second floor of my house every day, well, I say, do that more often because that's going to be a test. Or if they say, I walk my dog 3 blocks every day, but it's a flat ground, I say do that every day multiple times. Let's see what happens because that's your fitness level rather than trying to tell someone to make up a gym routine just to see if they're short of breath.
Okay. Thank you for that clarification. Can TAVR be used for aortic regurgitation?
That's a great question. I get that all the time, and I will tell you the answer is no, because I view it, and it's how I explain to patients. TAVR needs a foundation. So imagine if you're building a home. If you're building a house on ground, you want to build on solid concrete or solid rock to build a home. You don't want to build on quicksand. Aortic stenosis is basically a calcified valve. So when we put a new valve in there through TAVR, it has foundation to hold it in place. What is aortic regurg? It's a leaky valve, not a tight valve. So it's like building a house on quicksand. If you put a valve in someone with aortic regurg, you know what happens? The valve will sink literally into the outflow tract of the heart. So that's why there is no indication currently for TAVR to be utilized in aortic regurgitation.
Okay, thank you. Why does the patient have to be high risk in order to get the clip?
So another great question, because I've had people come to me and say, I don't understand it. You're telling me because I'm not ridiculously high risk, I should have open heart surgery? Because open heart is a scary thing, and I understand that. Here's the reason. MitraClip is not as good as surgical repair of the valve. So the gold standard for mitral valve disease is surgical repair. Surgical replacement is also very, very, very well tolerated and very well done. MitraClip does help, but it's not as equivalent in its data or its outcomes like a good mitral valve repair surgically done. So when I explain to patients that it's not like TAVR, TAVR is literally almost equivalent, if not better in some cases, than an open heart valve. MitraClip is not that. That's why it's only reserved for patients who are at the highest risk. Because anyone who is younger, more robust, naturally we want the best treatment for them. Even if it's more invasive, the mitral valve surgical replacement or repair, those are the gold standard treatments.
Okay. So if this person has a 10-year-old mitral valve repair, can the MitraClip be used?
So another great question. The answer to that is a in-between, a maybe. Because if someone has a mitral valve repair, we can sometimes put a clip in for a leaky mitral valve repair that's leaking again. Here's the issue. How did the surgeon repair the valve? Now, if the surgeon repaired the valve by taking a big piece out of one of the leaflets and leaving another piece a little longer, or doing so, because they do a lot of different things in surgery, we may not have enough tissue for us to put that clip in. That's why I don't tell every patient who has had a repair, you can get it clipped later on, because we don't know what that surgeon had done in the procedure. If the surgeon had left enough tissue for me to actually put a clip on, then we may have an answer, or we may be able to do that. So it really comes down to how that repair looks now and how much tissue is available for the clip to be put in.
Okay. Can you speak about why you might replace an aortic valve with a pig valve?
So the common animals that are utilized in all surgical or TAVR valves are either pig or cow. Those are the two animals that we utilize, and that's only because of data for decades, 70, 80 years of decades of data for those particular animal valves. So there isn't any hard answer of why those particular animals, only because they've been studied for so long and they've been used in the surgical valves for so long. They've been utilized now in TAVR valves because of that. We are seeing better data though with the pig valves than the cow valves when it comes to TAVR valves. So it could be how the valve is processed, how the valve is formalized, how it's on the valve itself. I can't say a particular animal is better for us to utilize. It's just that in these particular platforms, we are seeing the pig valves and TAVR do quite well. However, in surgical valves, there are plenty of bovine, porcine, cow, pig valves that do fine. But those are the two animals primarily utilized for all surgical and TAVR valves.
Okay, thanks for that clarification. Would it be the same approach for a 33-year-old with bicuspid aortic valve as an older adult?
33 would be extremely young. And a 33-year-old who has any issues with a bicuspid valve, usually a 33-year-old hopefully would not have major issues. But if they do, and I've seen it, it's usually related to their valve leaking, not as much stenosis. It's mostly a valve that's very, very leaky, or their aorta attached to the valve is dilating. And that happens, surgery is really the only answer. There's not a percutaneous or minimally invasive procedure to take care of that. So that would be 100% in my book, a surgical situation.
Okay. How bad does a mitral valve have to get before surgery?
So another excellent question, but difficult to answer with just the valve. If someone comes to see me and they have moderate leaking mitral valve on the ultrasound, like we call it an echocardiogram that's done on the heart, but their blood pressure is 180 over 90, treat the blood pressure. Let's see what happens. You'll be amazed at how much that leaking valve improves. If someone comes to me and has mild leaking mitral valve, but there is no blood pressure issues, we may just monitor that patient with a follow-up ultrasound in 6 months to a year, depending on how they feel. If someone comes in and has severe leaking valve, but their heart is dilated, now we're thinking, okay, maybe they're in heart failure. Do we need to put them on the right medications for their heart muscle first before treating the valve surgically? There are multiple pathways. So that question is difficult to answer with just saying, if you have this, you get this. Each person has to be individualized because there's going to be different therapies for each patient, which may not be surgery or MitraClip.
Okay. It's complicated. Is a heart murmur an indication of a valve issue?
So a heart murmur can be an indication of a heart valve issue, but a heart murmur can also be from something as simple as your heart muscle beating very quickly or very, very aggressively. It could be from flow dynamics across the chambers of your heart. It could be from other issues, maybe congenital issues in your heart. So it is definitely a part of heart valve disease, but it doesn't need to be only because of heart valve disease.
Is there any development of technology for tricuspid valve regurgitation?
There is, and actually we perform that procedure here at BCH. It's called the TriClip. We're basically where there's a clip for the mitral valve, there's a clip now for the tricuspid valve, specifically for the tricuspid valve. And that will be eventually a talk I give probably in the future about other valves and other valve diseases, but there is treatment percutaneously for the tricuspid valve, and of course, surgical treatment always exists for the tricuspid valve as well. But again, I'm going to reserve that. It's a whole different topic, so I'll reserve that for another time.
Okay. Is a CT coronary calcium scan in range of 300 to 400 suggestive of progressing to a valve problem?
So calcium scores are excellent tests. They do reveal calcium burden, but not necessarily disease. As in, what I mean is high calcium scores don't mean you have blocked arteries. It just means there is a likelihood that you're developing the chance of calcium in the arteries themselves. So high calcium scores are important because, number one, you should be on treatment for your cholesterol, be very aggressive about that, but it does not indicate one-to-one to aortic valve disease or valve calcium. It's more or less for coronaries, and that's what we utilize it for.
Okay. If a person has already had open heart surgery for a congenital bicuspid aortic valve, can they have a TAVR?
So again, for them to get TAVR, they would, number one, have to have severe symptomatic aortic stenosis. That would be the first and foremost issue. They have to have the condition for the TAVR. Second, it would be the age of the patient, because I have a number of patients who've had congenital surgery, but they're only in their 40s now, or maybe their early 50s, but they had it when they were children. Those patients would still be candidates for open heart, and the reason is the durability of these TAVR valves. We only have 10 to 12 years of data. Putting a new valve in someone who has a lifespan of 30 to 40 years tells me they're going to need more than one procedure. So better to have the open heart earlier and the TAVR later in the process, so they don't have to have open heart when they're older.
Okay, makes sense. If you already have heart valve replacement 20 years ago and it's time to replace it, can I do this PR9?
PR9.
That may be a typo. We can skip that one. Sorry about that.
No problems.
Would the clip you discussed be effective for tricuspid regurgitation also?
So going back to that prior question, there's now a device that we have called the TriClip, which is a specific device for tricuspid regurgitation. So yes, there is a device that we have that we utilize for that condition.
Okay. I believe that you said that the only option for a dilated aorta is open heart surgery. Is that correct?
Correct. For a dilated ascending aorta, the only option currently is open heart surgery. Now, if you had a dilated aorta in your belly, called an abdominal aortic aneurysm, or a thoracic dilated aorta in your chest, that can be utilized with something called a stent graft. That does not have to be open heart surgery. But if it's the pipe that's right attached to your aortic valve, there isn't a pipe we can put in right now because your coronary arteries come off that area. And science has not yet developed a tube to put through your groin to put there. That is still an open heart surgical procedure.
Okay. How does the risk increase if you need to fix both the dilated aorta and a bicuspid aortic valve?
There's always increased risk with increased procedures that are performed. However, this is very much bread and butter for any open heart surgeon performing these procedures. So in BCH, this is standard. These are not exotic procedures that someone would look at, and from our perspective, our surgeons would not look at this as saying, oh, it's an incrementally high, significantly higher risk. So this is quite standard. When we send patients to our surgeons for bicuspid aortic valve stenosis plus a dilated aorta, it's a very common procedure that's performed. So it's almost quite routine, to be honest. So it's not something that adds significant risk for their perspective when they do the procedure.
Okay. What procedure would be best for a leaky mitral valve and a leaky aortic valve?
So when someone has both leaking valves, it all depends on, number one, how bad are they leaking? Number two, how do they feel? What's going on in the heart? Is the aortic valve severely leaking and there's only mild leaking of the mitral, or vice versa? If someone has severely leaking mitral valve but only mild leaking aortic valve, those are the patients that would do great with a minimally invasive mitral valve surgery. But if they are, say, 90 years old, that may be a patient we would think MitraClip would be better suited for. For some reason, physiologically, the human body tolerates a leaking aortic valve well. I don't have a good explanation for it, and I'm not sure anybody does either, but for some reason, people can have a leaking aortic valve and not really complain and not see a lot of dysfunction. But a leaking mitral valve, for whatever reason, it does cause a lot more problems. So we tend to be much more proactive about a leaking mitral valve than a leaking aortic valve.
Sure. Are there any holistic supplements that can help?
Currently, unfortunately, there are not. Valvular heart disease is one of those mechanical issues where there's just not any medication, even if pharmaceutical, forget holistic, we can't even think of pharmaceutical grade that treats it other than the water pills that we had mentioned. There's really nothing else other than blood pressure control, water pills that treat some of these conditions, but they don't treat the problem. They treat the symptoms. So nothing is going to reverse a tight aortic valve, and nothing really reverses a leaking mitral valve other than the blood pressure control.
Okay. If a person has moderate mitral valve stenosis, why wait until severe to do TAVR?
So mitral stenosis does not get treated with TAVR. Mitral stenosis is when the mitral valve has calcium, and that is a surgical issue. That is not treated with TAVR. TAVR is only for aortic stenosis.
Okay. Is there any evidence that aortic stenosis is caused by exposure to Agent Orange?
There is not currently data to support that. However, I do treat a number of veterans. I've seen a number of people come to me with multitude of conditions from Agent Orange exposure. I think that's a topic that's still being investigated. And I do believe that there's links for a lot of negative things with Agent Orange exposure. Currently, for aortic stenosis specifically, I don't see that yet. But again, I will never say never, because it's been a number of conditions that are coming out every year, it seems, with exposure to these chemicals back in the day.
Okay. This person had an aortic valve replacement with a PIG valve, but it was over 20 years ago. They now have 3 valves that are leaking. What might be a good solution? They're 70 years old, but in good condition.
So a 70-year-old who has 3 leaking valves, including prior open heart, the situation can be quite confusing if you just go by just that. We need to see the person, look at them, see what their ability to recover from another surgery is, because at 70 years old with multiple leaking valves, if that prior surgical valve is having a problem, naturally the way I would bias this is to repeat open heart surgery. Because if they're that young, chances are, and they're doing well, hopefully they'll do well from another surgery, and in 15 years, if something should happen to that new valve, we can do something via through the groin without having to worry about a repeat open heart surgery after that.
We want to remind our audience that we do have a few more minutes. If you have more questions, please put them in the chat box, and we'll get to as many as we can. This person had a bovine aortic valve 11 years ago. What symptoms do they need to watch for replacement?
So the biggest issue is when someone has had a prior surgical valve, number one, they should be following up with their cardiology at least annually. They should be getting an ultrasound of their heart at least once a year, which is called an echocardiogram. That's just a basic evaluation. Symptoms, the big issues are, should they be having new shortness of breath, fatigue, like I mentioned prior? Those are things that are really important to keep an eye on, because if those start developing, well, that could be a sign that the valve has dysfunction. Usually these are symptoms that are progressive, so they'll notice it getting worse as time goes on. It won't be once and one and gone. It'll come every day, or it'll be progressive with every exertion. So it's important to keep an eye on that. But again, even if they don't have symptoms, these are the patients I try to tell once a year, follow up with your cardiologist, make sure that they have an evaluation of that valve, because when it does start getting more tighter or more leakier, we want to have an eye on it before it starts getting worse.
Okay. Is it then true that TAVR may be used for an old porcine valve that is beginning to fail?
So yes, a common use of TAVR now currently failed surgical valves. But like our questions that we've had before, we don't just jump into someone who had a surgical procedure, say when they were younger, and now they're in their 50s, we put a TAVR in. We don't do that normally because that patient will probably need another procedure later on. When we reserve TAVR for a failed surgical valve are usually the older population of our patients who aren't great repeat open heart surgical candidates. But yes, we can utilize TAVR in failed surgical aortic valve replacements.
What if you have calcification of the mitral valve plus regurg? Do either of the non-open heart surgery procedures work?
So for mitral valve regurg with calcium, there's one word we look for, and that's called gradient. If the number of pressure across your mitral valve is high, based on the calcium that's there, the MitraClip is not a good answer. Why? Because if we put a MitraClip in, there's a possibility of making that gradient, that number, higher and creating mitral stenosis. So we really have to be mindful of people who have a leaky valve with calcium. Usually, if the calcium is quite high or the gradient is quite high, surgery is the recommended approach. If a patient has a leaky mitral valve with a very low gradient despite calcium, clip can be done, but again, they have to be not good surgical candidates.
Okay. Do you have any other sets of information that you'd like to share with the audience tonight, Doctor?
At this point, just following up with your physician, your primary care, obviously number one, the most important, but if you do have a pre-existing cardiac condition, seeing your cardiologist on an annual basis or earlier or more often if needed, those are the best ways for us or myself and my colleagues to treat and diagnose is to know upfront what's happening. So if you have any of these conditions, obviously, please get checked out, get evaluated first. Don't wait to 2 in the morning coming to the emergency room and saying, oh my God, I should have gone in earlier. Because honestly, at that time, the heart has already gone through some suffering and some weakness. We want to get patients before they get to that point.
Okay. We do have a couple more questions we can squeeze in here. One is, this person had a previous MVP diagnosed 40 years ago, several echoes done and told minor significance. They're now 78. How much further investigation should be done?
One, I would say with a patient like this, just maybe once a year ultrasound of the heart, if not once every other year, depending on how they feel and how much leaking is present. But it is not one of those where any intervention or procedure is needed at this point.
All right, just 1 second here. If you have 2 moderately leaking valves, mitral and tricuspid, can the clip still be considered?
Moderately leaking, usually we don't do anything, to be very honest. It all comes down to the symptoms and how the muscle of the heart looks. If the heart muscle is weakening for any reason, or if there's any major symptoms associated with it, it can be discussed, but this is a case-by-case basis. I would never offer the clips right off. They have to first have a full discussion with their team to discuss whether or not they are A, needing anything, B, surgical, or C, potentially then come to the direction of doing these clips.
2 more questions. Does a 77-year-old person with mild aortic valve and shortness of breath need to do something?
Well, definitely for the shortness of breath, maybe not for the aortic valve, but again, remember, there might be something else going on there. And again, the lungs being the biggest culprit sometimes, where we always look at the heart and the valves and the arteries. If those are normal, naturally, I would be looking at the lungs as the next likely source, if not primary, depending on the background.
Okay. And does it matter if you have aortic valve leakage?
Well, it can over time, depending on how much. So any type of leakage, again, is not normal, but we want to make sure that is it progressing? Is the heart muscle dilating? And if it is changing, you should, again, going back to that ultrasound, it's a simple, easy test to have that echocardiogram. Getting that done once a year or how often your doctor feels necessary is easy and will really give a lot of information to your physicians.
We want to thank you for your time tonight, Doctor. It was very informational tonight. We have come to the end of our time and our questions. A recording of tonight's lecture is available at bch.org/livestream. You will receive a post-lecture survey by email. Please take a minute to fill this out. Thank you for joining us, and have a good night.